Welcome, everyone. Hi. So we're going to get started. My name is Dr. Mary Cushman. I'm a professor of medicine here at the Larner College of Medicine, and I'd like to welcome you to tonight's presentation. Thank you for joining us. We're so pleased tonight in this last lecture of the semester for Community Medical School to welcome former Vermont Commissioner of Health, a former Vermont Commissioner of Health, to discuss current debates in public health and explore how debate in public health issues can both raise public awareness and advance progress in public health policy. Dr. Jan Carney is a warrior, okay? And I say this because she's been involved for decades in implementing programs to improve the population's health. And that is sometimes warfare. I think you're going to hear about that. This work is truly difficult, but it is our best line of attack in preventing disease and improving the quality of people's lives. In tonight's talk, she's going to help us understand how this is done. Dr. Carney is Associate Dean for Public Health at the University of Vermont Larner College of Medicine and a professor in the Department of Medicine here at UVM. She received her medical degree from the University of Cincinnati College of Medicine and completed a residency in internal medicine at our old Medical Center Hospital of Vermont, which, as you know, is now known as the University of Vermont Medical Center. She also received her Master in Public Health from the Harvard School of Public Health in Boston. She's taught medicine at UVM for 33 years. Since 2011, she has been director of the University of Vermont Graduate Programs in Public Health, which she founded. She served the people of Vermont for 15 years at the Vermont Department of Health from 1988 to 2003, first as the Deputy Commissioner of Health and then as Commissioner of Health. That's a long time to serve in a role like that. I think we are quite proud of her. She also is influencing policy at the national level in two current roles. She serves on the Health and Public Policy Committee for the American College of Physicians, which is a group that represents internal medicine physicians. And in the medical education arena, she serves on the Association of American Medical Colleges expert panel on public and population health in medical education. So training our future physicians to understand these important issues. Dr. Carney is director of the Rural Health Research and Delivery Corps for a brand new $20 million 5-year grant awarded by the National Institutes of Health to both UVM and Maine Medical Center. The name of this grant is the Northern New England Clinical and Translational Research Network, and it aims to provide funding for investigators to improve health in our region in northern New England. So we'll have direct benefit to our region's health and to the well-being of our populations. On top of all of this, Dr. Carney is a prolific author. In 2015, she published a book, Controversies in Public Health and Policy, and she is currently working on another book, A Concise History of Public Health. So with this, please join me in welcoming Dr. Carney to deliver her talk to you tonight.
Thank you very much, Mary. All right, here we go. My only disclosure is I do receive some royalties for my book. Okay, I put this on to show you that a lot of the work I do involves populations and prevention. And that prevention may be in the talking one-on-one to people or to a group of people. And this is sort of the notion of public health. Here's the objectives. We're going to talk a little bit about some of the factors that are involved in controversies, politics, money, research, maybe not so much research, discuss some current issues, talk about the opportunities. Often people are put off or scared by controversies, but sometimes they may be opportunities to get progress moving and have fun. All right, this is what we're going to talk about. Let's start with, does sitting kill us? Let's find out. First, a little context about physical activity, because I think that's really important. The benefits of physical activity are many. It reduces our risk for many diseases. We live longer, and we only need to get 2.5 hours a week. How many do that? All right, then. Well, not everybody else does. So here's a map in the United States, and I think this is part of fun, to show you that there is a lot of variation in some of these habits and behaviors. And this is the percent of adults who engage in no leisure time physical activity. And it's about 25% across the country. And you can see in Vermont, we're in the best quartile. And we can see more down in the south, not so much. Then, so all this evidence that we know about physical activity then came out, too much sitting. And that's a problem. So that came out in the American Journal of Preventive Medicine, a well-respected journal. And I'm going to show you a little bit about this study to show you kind of how they're done. This looked at, and this was in 2014, they want to look at the relationship between sedentary time and deaths from cardiovascular disease, coronary heart disease, and cancer in a very large multi-ethnic group of postmenopausal women. So there's more than 92,000 women in the Women's Health Initiative. And what they do is they survey them like every other year, and they ask them to report on a variety of different things. And so they looked at 4 categories of sedentary time: 4 hours or less, 4 to 8 hours, 8 to 11 hours, or more than 11 hours. And in case you're wondering kind of what's the average of time people sit, people have studied the epidemiology of sitting, and both men and women sit on average 5 hours a day. And we know that some people sit more. So they followed them for 12 years, and the important thing here is they controlled for all these other things related to these diseases and death, like tobacco use, weight, and how much exercise they got. So in that 12 years, they found that the highest amount of sedentary time had the highest increased risk of death in all causes, and also for coronary heart disease and cancer deaths. And the bottom line is there was a linear relationship. The more sedentary, the more time sedentary, the higher your risk for death, irregardless of whether or not you went to the gym every day. So it was the sitting that they separated out. All right, more evidence. And then, this was just in 2017, and this was done a little bit differently. And the one I just mentioned, they asked people like how much time they sat. In this one, and this was 8,000 people, adults, age 45 and over, and what they did was they put this little thing, and it's about this size, called an accelerometer. So it actually recorded how much you moved or not. And what they learned from this study was it was not only the total amount of time you were sitting, it was also whether that time was interrupted or not. So the LA Times picked up on that and said, get up every 30 minutes. So you're more than welcome to stand up during the presentation if you want. And that is the current advice. Get up and stand up. Let's go on to e-cigarettes. Before I leave sitting, some people have asked, is sitting the new smoking? My answer to that would be no, because smoking is the same smoking. So we're going to talk about e-cigarettes, but before that, I wanted to sort of put that into context about trends in cigarette smoking among high school students and adults. And you can see since 1960, it's gone down in adults. And that curve that peaked in sort of the mid-90s was a disaster all over the country. I was very involved in that here and trying to have a public health approach to help prevent high school students from starting to smoke. And that has since gone down in a substantial way. Why is it so important to prevent young people from starting to smoke? Because 99% of all smoking starts before age 26. So the corollary is if you can prevent young people from starting to smoke till they're that age, chances are they will never smoke during their lifetime. So again, another map. And let's see, who should we pick on this time? This is from CDC and shows the variation in smoking cigarette use among adults across the country. And this time, take a look at where it's very, very low. Utah. What's that all about, do you think? Yeah. And again, it's very high in the South. And what's that all about? I heard it. Tobacco companies. I know I heard it. All right. And this just a reminder of, again, unfortunately, despite all our progress, despite those trends, cigarette smoking remains the leading greatest preventable cause of death in our country today. More than 480,000 deaths each year. And you can see that it's associated with all of these different chronic diseases: cancer, heart disease, lung disease, and many more. Okay, e-cigarettes, what are they? They started about 2004, I think from Beijing, and they're also called electronic nicotine delivery systems. And what they are, they have a little battery, rechargeable battery, and it heats up liquid nicotine and something to make it into a vapor, which is either a vegetable glycerin or propylene glycol. There are more than 400 brands and over 7,000 flavors. And what's particularly noticeable is how much the advertising has increased from even 2011 to 2014. The global sales are near $2 billion. The growth will continue. And in Vermont, even though our cigarette smoking rate has dropped very low, 30% of high school students have used electronic vapor products in 2015. I want to show you some of the comparisons between the advertising from cigarette ads decades ago and then the e-cigarette ads. So the ones on the left are, there's the Marlboro Man, and the ones on the right are the e-cigarette ads. And here's Lucky Strike and Smoking in Style. Stanford has a big tobacco research collection, and they do a lot of research, and they make that available publicly to look at research about advertising and tobacco use. Another big theme, that's Joe Camel on the left, is freedom. And having the freedom to use some kind of product any place, because these really circumvented all the tobacco laws. You can see the advertising. We can't advertise cigarettes like this. You can smoke them anywhere, despite the bans in public places. Certainly that's true across the country, but different states may have enacted certain restrictions on them. We have here in Vermont, and also on our UVM campus. So what about this advertising and youth e-cigarette use? This does not show cause and effect. It's from the CDC, but it shows the relationship between the past 30-day e-cigarette use among young people and the increasing number of dollars spent on advertising. And here's some of the specific ones that are targeting young people. Now, what's the concern here, and what's the controversy? We'll get to the controversy in a minute, but some of the concern is the rising youth in young people. You can see these are statistics from CDC, and on your handout, there are a lot of these references on there. So in the past 30-day use, it's increased 10 times for high school students and almost 9 times for middle school students. In a 4-year period, nearly 3 million students, or 1 in 7, have used them, past 30-day users in 2015. The one I'm most concerned about is that in 2013, more than 250,000 middle and high school students who had never smoked cigarettes had used e-cigarettes, the ones who had never smoked cigarettes. And why is this a worry? Because nicotine is highly addictive. It's not good for the developing brain. We know it's the reason why everyone knows that smoking is bad for you, why it's so hard to quit. E-cigarette, and this was studied and more recently studied in young people. So e-cigarette use is associated with an increased intention to smoke cigarettes among young people in one study. Another study from Los Angeles, high school students who had ever used e-cigarettes were more likely to report using other tobacco products within a 12-month period. So the worry is that young people using them who not currently smoke may have an increased intention or actual use of conventional cigarettes. Indoor air, that harmless water vapor. Well, it's not. And that article that's cited there is actually the scientific review from the American Heart Association. It's an excellent summary of all the research up through 2014. So what's in this? What's in the vapor? Nicotine, heavy metals, ultrafine particles, irritants, potential carcinogens, probable carcinogens, and then formaldehyde-releasing agents, which are also carcinogens. Adults using e-cigarettes, less than 2% use them without using cigarettes. The worrisome statistic is among adults who are past 30-day users of e-cigarettes, more than 3/4 were also still smoking conventional cigarettes. One of the questions is, all this advertising, all the increased use, are they safer? How much safer? They must be safer. There's a lot of perceptions around e-cigarettes. They're safer. They're used to help quit smoking. And actually, a study didn't come out till March of 2017 that actually looked at this. There was 181 people, and they measured the amount of nicotine and tobacco-specific N-nitrosamine, which is carcinogen, VOCs, volatile organic compounds, in the saliva and urine of people who were using nicotine replacement therapy alone, e-cigarettes alone, and then people were using them in various combinations. And what they found was in the people who just used nicotine replacement or just used e-cigarettes without anything else, they did have a reduction in the amount of the carcinogens and the toxic VOCs. But remember, in the context of this small study, that of that high proportion of people who reflect dual use, and there was not those reductions seen in that group. So, adults in smoking cessation, they are not an FDA-approved quit smoking aid. The FDA actually regulates nicotine replacement, other quit smoking aids through its Center for Drug Evaluation Research, which is a different place in the FDA than tobacco products are regulated under the Family Smoking Prevention and Tobacco Control Act of 2009. Now, how good are they compared to what the other things that we have to help people who want to quit? There was a randomized controlled trial in New Zealand, more than 750 people, and these authors, that should say modestly effective, found them similar to nicotine patches, but actually the abstinence rate from cigarettes was actually quite low. That was probably the best study that was there. One of the points with e-cigarettes in adults is that a high number of dual users and not quitting completely carries continued health risks for people, and they're substantial health risks. Even if you cut down in half, still people have a high risk of premature death. Versus quitting completely, where heart disease risk is cut in half in a year, and even if people don't quit until they're 50 years old. So, from all this, lots happening, a lot of e-cigarette use. Attorneys general in 40 states in the US in 2013 petitioned the FDA to regulate them, particularly worried about adolescents and young people. And American Heart Association, other medical groups, also please, you have the authority under this 2009 law, please put on some restrictions like we have for conventional cigarettes. So some time passed. Then what happened? This is where some of the controversy comes in. In 2015, Public Health England, which is like the CDC in England, came out with this 111-page report that said e-cigarettes are 95% less harmful. Whew, no worries. Well, not very long after, The Lancet, which is a prestigious medical journal in England, said, Public Health England's evidence-based confusion. They pointed out that that 111-page report had no science in it at all. As a matter of fact, there was a panel, and they weren't even tobacco experts, and they basically ranked the harm of nicotine-containing products. So they ranked 99% harm of conventional cigarettes, and e-cigarettes they ranked as 4%. So if you just subtract, that's where the 95% came from. And to make it even worse, one of the people on the expert panel had financial ties to the e-cigarette industry. So, and on we go, and it gets better. Dr. Richard Carmona, who's a former U.S. Surgeon General. This came out in the New York Post and also in 2015, and he's telling us all to get a grip. These are going to save millions of lives. The problem is, he was on the board, and still is on the board of directors for Enjoy, one of the e-cigarette companies. Finally, 2016, the FDA claims authority under this 2009 law in terms of regulations for e-cigarettes as some of the products that it's regulating. However, then we had an election. Oops, now they're delayed again. And this was in July 2017. So as of right now, we still don't have any regulations for e-cigarettes. And then they announced, the FDA announced, also in July, that they're going in an entirely new direction with tobacco products. Dr. Scott Gottlieb is the FDA commissioner. And what he published in the New England Journal, and this is just at the end of September, a nicotine-focused framework for public health. So what they're proposing under their authority, under the federal law, under that same Family Smoking Prevention and Tobacco Control Act, is that we reduce the amount of nicotine in conventional cigarettes. They have the authority under that law. They're not permitted to reduce it to zero, but they have the authority. And so, isn't that interesting? Well, if you reduce the amount of nicotine in cigarettes, won't people just smoke more? That was one question. Black market considerations, on and on and on. So, but actually there was a study also published in the New England Journal in 2015 that tried to answer that question and had maybe 650 people who were, or 700 people who were randomized to continue to smoke conventional cigarettes, their type of cigarette, or to one of 6 cigarettes that had controlled amounts of nicotine, regular nicotine amounts, all the way down to very low nicotine amounts. And nobody knew who was smoking what until at the end, and they counted at the end of 6 weeks how many cigarettes people were smoking. So, and they found that at that 3 lowest level of nicotine in the cigarettes, the people were smoking significantly fewer cigarettes. What that meant was that compensatory smoking, if there's less nicotine in the cigarette, they weren't smoking more. Very interesting. They were still smoking, instead of just over a pack a day, 15 cigarettes a day, but it showed that certainly this approach was something very interesting. So we're going to see where this goes. Key points. E-cigarettes are still unregulated, expansive growth in marketing. We talked about the youth and adolescent concerns. Harm reduction over the long term. Do we really know? We have very few studies that show us the actual harm or what they actually do to health and disease. The concerns are the dual use in adults, the flavoring and the marketing for young people, and what's in the vapor. Clearly, we need a lot more research, and many professional organizations continue to advocate for regulation of these, particularly with regards to children and adolescents. This is a topic that's really hard to talk about, but I think we need to talk about it. This picture, actually, when I was on vacation in Maine this summer, I took it and to remind me that in our country, we have people with a variety of diverse views, very intensely held views of this issue. So I want to talk about the epidemiology, homicide versus suicide. The research, we have too little and it's too old. How come? What works? Mass shootings, and what can we do? In the United States, over a 9-year period, there are more than 300,000 deaths from firearm-related injuries, and I'll let you read the rest. In 1989, the American Medical Association called it a critical public health issue. In 2013, there was a renewed call for a public health approach to prevent gun violence, and I'm going to talk more about what a public health approach means. So homicides and suicides are more than 96% of all firearm-related fatalities. Some of them are unintentional injuries, what we used to call accidents. For example, when someone drops a firearm and it goes off. Over the past 30 years, most deaths are suicides. About 2/3 of the firearm-related deaths in 2012 are suicides. And since more than 10 years ago, homicides have decreased and firearm suicides have increased. And I'll show you this in just a minute. We have in 1 year, more than 32,000 deaths from firearm violence, more than 20,000 suicides, and more than 11,000 homicides. Firearms are used in nearly 70% of homicides and more than half of suicides. And for suicide attempts, we know that more than 90% of the time, those are lethal attempts. In that 10-year period, we have more than 80 deaths per day, almost 50 suicides per day. And it varies among different ages and race, ethnicity. It's the leading cause of death for black men who are between the ages of 15 and 24. And the increase in firearm suicides is mostly in white men. So this is from the Pew Research Center. Ordinarily, for public health issues, you might go to the CDC website, but you can't really find these kinds of graphs there, and I'll explain to you in a minute why that is. So you can see from 93 to 2010, certainly since about the year 2000, that we've had a stable rate of firearm deaths. And you can see the dotted line is a suicide, and below that's a homicide, and the increase in one and the decrease in another kind of cancels each other out, and we sort of have a level rate since that time. Again, this map is from, I had to go in and make this map on the CDC website. It's from their web-based injury statistics query and reporting system. And this is homicide death rates across the country. And you can see the darker areas, the dark blue and more the turquoise color are the higher rates. You can see that's the South, and pretty much the South across the country. You can look up in Vermont and New Hampshire, Maine, and see for homicides, we're in the lowest quartile. Now, compare and contrast this to suicides, and it looks very different. And if you look at Vermont and Maine, it's definitely, we're not in the highest category, but higher. And then can you look at the western part of the United States and some areas of the South? So you get a very different picture. So on all of these things that I'm talking about, that you see that there might be something across the country as a whole, but there's tremendous geographic variation within our country. So here's some information from the Harvard Injury Control Research Center. Basically, where there are more guns, there's more homicide. So where's the rest of the research? Good question. And here's what's happened. In the 1990s, the NRA started lobbying Congress. And in 1996, there was a congressional budget amendment that prohibited the use of any federal funds for research to advocate or promote gun control. This is called the Dickey Amendment, after Congressman J. Dickey from Arkansas. So during that year, in 1996, they took the $2.6 million spent on firearm research and they reallocated it to traumatic brain injury research. It was not till much later that President Obama signed an executive order for the CDC to conduct gun violence research. And that was Sandy Hook was in 2012. But they really didn't do it. And here's how come. This is the Appropriations Committee report of the U.S. House of Representatives in 2016. And it's more than 260 pages long. And if you wade through it and you find on page 47, this is what you see. They're continuing. This is the committee that allocates all the funds to the federal agencies. They continue the general provision to prevent any funds from being spent on gun research to include collecting data for potential future research, such as the National Violent Death Reporting System. Now, the National Violent Death Reporting System was created in 2002. And in addition to information from death certificates, it includes autopsy data from medical examiners, law enforcement agency data, toxicology reports. So from that collection, on a population level, you can tell if there's a cluster of suicides. You can tell if robberies are associated with homicides. You can tell a lot of different, whether they were a homicide was someone who was an intimate partner, for example, which we know is a common cause and a common contributing to homicide. So this system, despite the fact that this funding really is curtailed, has managed to expand in some way to 40 states, Puerto Rico, and the District of Columbia at the current time. But you can see that in 2016, the budget request was not funded, and they reminded the CDC about the Second Amendment and this prohibition. Then, in 2017, this sort of happened and without too much fanfare. This is just to show you the NRA's website, and this is their Institute for Legislative Action. And you can look on that and see what they are supporting and what they're opposing. So, prohibitions on research, the studies that I showed you, they're pretty old. So what do we know? What works? Gun buyback programs. People thought that they might be an effective way. You give people cash or gift card we know that more guns in an area are associated with more homicides. So maybe if we figure out a way to have less guns, there'll be less homicide. That was the idea. But what happened was, for example, in Wisconsin, the guns they recovered were not the same type that were used in the homicides and suicides. In Hartford, Connecticut, they collected some over 4 years, but it was minuscule amount compared to the numbers being sold. But only in Boston was there a very interesting thing happen, that they did this gun buyback, but it was along with a community prevention program. There's a lot of education. You didn't just take your gun to the police station for cash. There were a variety of community agencies where you could do that. They collected more than 1,000 firearms, and their gun violence decreased by 30%. They couldn't say it was just due to that. It was more likely a result of those comprehensive efforts that they did. Laws and policies. This is a little bit busy, but let me just simplify it, go through it quickly. Missouri had a handgun purchaser licensing law, and they repealed it in 2007. So then that was associated, after that they saw an increase in their annual firearm homicide rate, and also an increase in firearm suicide. Connecticut had a handgun permit to purchase law in 1995, and that was associated with a reduction in firearm homicides over a decade, and also a reduction in suicide. There's another study that showed in US states that have more laws, there are fewer firearm deaths, fewer homicides, and fewer suicides. The problem with this type of study is it's like at the 30,000 foot level. So you sort of can see an association between a state and the number of laws, but it doesn't really tell you a lot of detail. And you can't really tell cause and effect. In 2017, this was actually just came out in October in the Annals of Internal Medicine. The state laws prohibiting subjects with that's intimate partner violence related restraining orders. So if someone gets a restraining order against them, they're prohibited from having a firearm, and actually the ones they have were taken away. That was associated with lower homicide rates. But it was funded by Robert Wood Johnson Foundation. This situation's a little bit different. Australia had a mass shooting in 1996. And at that time, after that time, they passed gun access restrictions that were really substantive. Semi-automatic pump-action long guns. They also did a gun buyback in 1997 and got 650,000 firearms bought back. And that represented 20% of all the firearms in the country. They've had no mass shootings 20 years later. Now let me explain to you what's going on here, because the authors couldn't really conclude. It was not possible to determine whether these changes were directly related to the law. Before they passed that law, they were starting to see a decline in firearm deaths and suicide. After the law, it went like this. But because it was beginning there, they couldn't conclude that the law, it was cause and effect with the law. But they have seen quite a number of substantive changes. Commentators, in writing about Australia's situation, also observed that the magnitude of this, they editorialize, is not likely something, at least at the present time, that our country would favor. Mass shootings. 2012, Sandy Hook Elementary School. This is from the New York Times. In the absence of federal funding, restrictions on research, and an absence of scientific studies, there have been many excellent investigative reports through large newspapers. So they looked at, a year later, gun laws enacted. There were 1,500 gun bills introduced, 109 became law, 39 tightened gun restrictions, but 70 loosened them. This came out after the Las Vegas shootings. Similarly, things came out in major medical journals. This is also from the New York Times. Why do we ignore initiatives that reduce gun violence? We know that programs such as Boston initiated and actually worked with, were a community initiative, did have an impact on the community. We don't know if those same kinds of programs, for example, will work in another city. So what do we know about what the public is thinking now? And a little bit about gun ownership in the United States. This is from the Pew Research Center. About 4 in 10 U.S. adults say they live in a gun-owning household. An earlier study from 2004 showed that of gun owners, of those guns, about 60% were long guns, meaning rifles and shotguns, and the vast majority of those were used for hunting and sporting purposes, 77%. So 60% long guns, 40% handguns, and of those handguns, 50% were obtained for the purpose of protection. The majority of gun owners own multiple guns. About a third have one gun, 2/3 have more than one gun. Majority of gun owners say stricter access to guns would not decrease mass shootings. This is a 2017 survey. And I put the link on the reference page so that you can look at this. There's a lot more detail in this research than we're able to show. And you can see for all adults, less than half said it would result in fewer mass shootings, almost 40% no difference, and some thought it would result in more. And then there was a difference between people who own guns and who didn't. And on the far right is 2017, but you can see we the public is just almost evenly split as to controlling guns or protecting people's rights at this point in time. All right, just a minute on a public health approach, and what does that mean? Dr. David Hemingway and Matthew Miller published this in the New England Journal of Medicine 2013. It is population-based. So it looks at the population, not individual behaviors. It depends on data and research. It focuses on prevention. What that prevention encompasses is there's things for individuals, but there's things that look at the environment, and are there factors we can change to prevent something in the environment, and what's called the agent. So I'm going to use the example of motor vehicle crashes. So in that case, the environment would be the roads and the car or truck or whatever motor vehicle would be the agent. You use a systems approach. You look at what is the system that creates protections for people. It's broad, it's multifaceted, it's collaborative. You have people, doctors working with public health officials, nurses, teachers, law enforcement. It depends what the issue is, but it's a collaborative approach. It involves, the laws are the lightning rod here in our discussion of firearm injuries, but a public health approach includes policies or laws, programs, and also changing social norms, and emphasizes shared responsibility as opposed to trying to point the blame for every single event. So let's use the example of motor vehicle crashes. Decades ago, people were driving, they'd crash, they were impaled by the steering column, the windshield would shatter, they were thrown out of the car, they could hit a tree, they could hit a telephone pole, or they could have a head-on collision with somebody coming down the road the other way. Researchers, some of the best research on this was done at Johns Hopkins University by someone named Susan Baker, who spent an awful lot of time in the medical examiner's office. And suddenly, people started to, it wasn't sudden, it actually evolved over time. People started to think about, how can we think about this different? How can we think about the environment and the car itself? And as you know, we have collapsible steering columns, the windshields don't shatter. Now we have seat belts and airbags and guardrails and medians between big highways. And sometimes I think they even have, the phone poles will even kind of fall over if you hit them. Quite a lot. What other kinds of things? Policies, programs, social norms. Policies and laws. We had driving under the influence, huge contributor to motor vehicle deaths. So we have laws about that and enforcement of those laws. Programs, educational programs, broadly educational. And social norms, where it became no longer socially acceptable to drive under the influence. So all these things together. And that was a shared responsibility, all these different pieces. You didn't neglect the individual, but you didn't rely just on that individual to change and become a better driver in order to prevent the consequences of motor vehicle crashes. And what happened was, for every mile driven in our country, motor vehicle deaths have declined by 80%. So what Doctors Hemingway and Miller are suggesting is perhaps, and this similar approach, analogous approach, has resulted in that decline in cigarette smoking, both among adults and young people that I showed you earlier. Thinking about perhaps we need to change the conversation. So I'm going to stop on this issue with that and go on to health versus healthcare. It's complicated. It really is complicated. But before we get into that, I want to talk about health and healthcare and what determines health. Health is determined by healthcare and much more, all these other factors. This is 2007 from Dr. Stephen Schroeder, who was the head of Robert Wood Johnson Foundation. And this came from some earlier work to estimate the proportional contribution to premature death. So if you die before your time, what are the factors that might contribute to that? And about 30% of the time, it's genetics. Right now, we can't change all of that, although at the rate we're making progress, that may not be true in the future. 15% social factors, a percentage due to the environment. Healthcare is 10%. It might be a little bit higher with some population-based models that we have now. And the habits and behaviors are things we're talking about. Whether or not you are sedentary, if you have a good diet or not, if you're obese or not, whether you use tobacco products or not. Those are the kinds of behaviors that really contribute to chronic conditions of premature death. So those social determinants, what do we mean by that? Because you may hear a lot more about that now. It's things like whether or not you're employed and what is your income level. Do you have adequate housing? What's your education level? Do you have sufficient food? Or do you have access to healthy foods? In many places in our country, there's called food deserts where people do not have access to grocery stores. Are there social support systems? Is there discrimination in the community? And for health, the healthcare system, is there health insurance? Are you covered? Is there someone to go to? Is your provider, your health provider, understand your own unique culture? Is the quality of care high? So all these factors are important. Heart disease is, in terms of the causes of death, these are chronic conditions now as opposed to 100 years ago where infectious diseases were much more commonly killed people. So heart disease, cancer, respiratory diseases, unintentional injuries, stroke, diabetes, Alzheimer's disease, and on. And this reminds me to tell you about the health department. That's another reference on your handout. They have something, they're talking about something called 3-4-50. 3 behaviors contribute to 4 chronic conditions on this list, result in 50% of all deaths in our state. And I think that's a great way to think about it, and it's all focused on what we can do to prevent chronic conditions. Why else do we want, besides people's health, is there another rationale? Yes, if you have a chronic health condition, it's associated with much higher healthcare spending. And you can see the red is if you were never diagnosed with one of those same chronic conditions, or if you've ever been diagnosed, and the costs are about on the order of 3 times higher. So it makes sense to try and prevent them whenever we can. The other thing working against us is our demographics. And we know that both individually and as a population, we're getting older. And that it will continue. And as people get older, they may be more likely to have a chronic health condition, and healthcare expenditures are also higher. The other demographic factor is that we're becoming more diverse as a population. This is data from the Kaiser Family Foundation from 2015 and projects to 2045, whether we're the proportion of people who are white or people of color. Why is that important? Because we currently know that whether you're a person of color or not, there are differences in survival, access to health care, risk factors for certain behaviors, and they're called health disparities. And unless we are able to do something about that, as the population becomes more diverse, those will only get worse. resulting in not only poor health, but also higher costs. So how much do we spend as a country compared to our peer countries? About double. And you can look at us, we're at the top in per capita costs, and our comparable country average is in the middle. And again, as I've shown you before, this is not uniform, and it varies across the country. So that generally, the Northeast, but all across the northern latitude, you can see the darker colors are higher healthcare expenditures per capita. Cost. People, some of this is controversial, and people debate the exact proportions, but this is from Robert Wood Johnson Foundation, and these are some of the general contributing factors why costs might be higher in our country. Higher costs of insurance administration. Some of the factors driving spending growth relate to our use of medical technology, the proportion of our population that's obese. Reimbursement incentives refers to fee-for-service payment to reward pay for more services. However, we're seeing shifting models, particularly since the Obamacare, of experiments with looking at different payment strategies that would not be a fee-for-service model. And then some of these are less important. Access to insurance. If you don't have insurance and you get insurance, do you suddenly go out and do you accumulate a lot more health care costs? Maybe some, but that's one of the less important factors. Okay, obesity in our country. This shows on the left from 1986 to more than 20 years later. And it goes from the different shades of blue through the red. And you can see as a country, and then also the areas of the country where this is even worse. That is about 30 pounds overweight if you're 5'4". And the good news is that in young children, we're starting to see progress in some states in the country, but this still remains not only a major driver of chronic health conditions and poor health outcomes among people in our country, but also contributes to costs. It's a very important report came out in 2013 from the Institute of Medicine, and it was called U.S. Health in International Perspective, Shorter Lives, Poorer Health. We spend more on health care than our peer countries, but Americans are in poorer health and live shorter lives. They called that America's health disadvantage. And they said that that was due to a combination of things, including inadequate healthcare systems, unhealthy behaviors, social and economic factors, environmental factors, such as think about how neighborhoods are configured and you have to drive everywhere. We have the lowest life expectancy at birth among comparable countries. These are one of the fundamental measures of the health of a population. And then you can see the country average is in blue in the middle, and that we are at the bottom. And this is nothing new. Since 1980, there's been slow increase in life expectancy in many countries, including ours, but the rate of progress in the United States has consistently lagged below that of our other peer income countries. We're worse in 9 areas compared to many other countries who have similar incomes. Infant mortality and low birth weight, injuries and homicides, we mentioned some of those. Teen pregnancy and sexually transmitted infections, HIV and AIDS, drug-related deaths, obesity and diabetes, heart disease, chronic lung disease, and disability. Now, what I notice about these is that even if our entire population had health insurance today, that would not be enough, right? Health is more than health care. Combating or improving all these different things will take a greatly strengthened public health effort. Looking at the health of the population, stronger, even stronger connections between health care and public health or population health. We do that very well here in Vermont as a nation. If we're going to see improvements in our life expectancy and our outcomes, we need to do a lot more. Health insurance, just because that's also many new health proposals out in the news, and many of them are very, very controversial. But our country's discussion, debate, and struggle and controversy with health insurance is not new. This is first in 1918, where health insurance, the umbrella protecting from the reign of destitution and sickness. This was in the 40s with Harry Truman, and they were trying to make reforms, and this was organized medicine response. Then in the 60s, we had Medicare. That was controversial. In the 90s, remember the Clinton plan? That didn't go through. And then 2010, we had the Patient Protection and Affordable Care Act, commonly known as Obamacare. And that had extensive debate and compromises. Consideration of a public option was not something that worked. There was a co-op option instead. There were other compromises in that bill, but that passed in 2010. And I want to show you some of the data since then from Kaiser Family Foundation. This starts in like 1972, but I want you to look at that 18.2, which is just around 2010, and now in 2017, it's down to 10.4. And this is the uninsured rate among non-elderly population. So that means people less than 65, because at 65, you'd be covered by Medicare. And as I showed you before, there's tremendous geographic variation. This is the uninsured rate for people who are under 65. And again, the highest rates of uninsurance are particularly in the southern states across the country. Now, even if Obamacare is fully implemented, we would still not have universal health insurance coverage. But you can see from that earlier graph, a lot more people are insured who were not insured before, despite the fact that we still have a lot of disparities in our country. Okay, recent health reform proposals. On the bottom is the Affordable Care Act. There have been 5 since May of 2017, and there they are. You read about it, you hear about it. The Congressional Budget Office puts out some kind of report trying to unravel. These are very complicated. But the question that I was asking and wondering, how can we look at these and decide whether they're improvements or it will make things worse? And I found this from the American College of Physicians. And they're the largest specialty physician organization in the country. They do extraordinarily thoughtful policy analyses, work collaboratively with other healthcare organizations, and most importantly, they advocate for what's best for patients. So these are kind of the 10 questions in evaluating whatever new proposal comes out. Can people who currently have coverage keep it? What is the cost to patients? Right now, there's tax credit premiums, cost-sharing subsidies. There's eligibility for financial help depending on your income, your family size, where you live. This is in that Kaiser Family Foundation. There's a calculator that you can just plug in and find out your eligibility no matter where you live in the country. Are there incentives for young people to buy insurance? What about these essential health benefits? There's a range of benefits currently covered. Will these be limited? Will women have to pay higher premiums? What about Medicaid changes? Many states have relied on Medicaid expansion to insure part of the population. Pre-existing conditions, will people have to pay more? Are there prohibitions against lifetime limits? And then remember, in that discussion about health and health care, is there support for public health, prevention, research, primary care training, and innovative healthcare models. A lot of the new models, and you have that on your reference, also the Blueprint for Health, and looking at ways that we can try and prevent and manage chronic conditions in the population. So will there be continuous support? And bottom line, is the total number of people covered with essential benefits at affordable costs and consumer protections better or worse? Those are some of the questions you can ask when you see these proposals, and you can look on the website, some of the websites that are provided, and they do a thoughtful analysis of some of these. Last thing, as I was thinking, all of the things we've talked about really are controversial for a variety of reasons. Sometimes it's money, politics, government, research, arguments about research, not enough research, and on. But what I was wondering is, what might possibly be the next controversy we might see? And you'll have to decide about that one. All right. Thank you very much. And we have time for questions, and if you just raise your hand for a question, and we'll bring you a microphone.
If there's a direct correlation to health and the amount of sitting, but there's no, I never hear about any recommendations for, sit less than 3 to 5 or 8 hours a day. Is there a recommendation that I haven't heard of?
It's just, no, the question was, is there a recommendation for the number of hours we should or should not sit? The less you sit, the better for your health. That's it. There's no hour recommendation. Most people sit at least 5 hours, and you could see from the studies that people were sitting now more than 11 hours a day. Now, add that to the time you sleep, and you wonder what people are doing, right? But most important thing is to remember that the less total time sitting, so you see a lot of these standing desks, and then get up every 30 minutes. Just stand up. Now, why is this? We don't understand the mechanism of that. Some people think that this sitting somehow causes some changes in our metabolism that might, again, promote risk factors for disease. But we don't entirely know that. But I think it's less sitting and get up more, walk around periodically.
Hi. Thank you so much. Hey. I had a question about those 2 graphs you showed. The first graph was on I think it was the chronic disease map, and it showed sort of that stroke belt in the south.
Yep.
And then the other graph was the insured rate, and it showed that people living in the north, not in that stroke belt, are more insured. And I guess my question is, if you could just sort of elaborate maybe a little more, like your thoughts on why that trend exists, and if it were to change, and I guess we could just say the South were to become more insured, how would that affect healthcare expenditures and decreasing chronic disease burden in the United States? And I guess ultimately, do you think that would improve our global ranking in the world?
I can't repeat that whole question because it was too complicated. No, but basically, sort of, when you see those maps, how do all those maps kind of fit together related to healthcare, and kind of what does it mean if we try and make that better? A lot of the health risks for chronic diseases, obesity, tobacco, right, were much higher in the South. Healthcare spending per person was lower in the South. Uninsured was higher in the South. All right. So what does that tell me is that both we need to have a focus on public health, prevention, right? All those habits and behaviors we talked about, as well as efforts to have people have access to health care, and you reinforce that. So it's a combination of both. And it really is. One of the proposals on the table that I showed you on that list since May tried to reallocate some Medicaid funds to the South to help with that. Some of those states have not expanded Medicaid to help with that. So it's really a precarious situation and needs help in both from the public health and the healthcare side.
Okay, this is back to the about sitting is bad for your health. I have a friend who's a doctor, and she's always on the go. But we were playing cards one night, and she said, even kneeling or standing or laying down is better than sitting. And I thought that was very interesting. She would jump up while we're playing cards, or she'd kneel. And I was like, so, what do you think?
I haven't seen that formally studied, but I would go with it.
Okay.
Hi. What do you feel are the unintended consequences of decreasing the smoking rates in the country? I mean, there's been some debate that in terms of health economics that it's increased our expenditures because of the less likelihood of somebody dying from a sudden myocardial infarction at around the time of retirement. And there's also some evidence that maybe it's linked to the increasing rates of obesity. I was just wondering what your thoughts are on that issue.
Is the question why the smoking rates aren't further declining?
No, what are the unintended consequences of us decreasing smoking in the U.S.?
Of decreasing smoking are, there was a very controversial paper published now years ago that said if we lowered smoking rates, costs would go up because people would live longer and die from competing causes and accumulate more health care costs. People don't smoke cigarettes and then just die, usually. They suffer. They have chronic conditions. They get sick over and over again. So we have to think about, I think we have to think about cost, but we have to think about health. If we reduce smoking to as close as possible, as low as we can, people will enjoy greatly improved health. And that longevity, they will live longer. It's likely their quality of life will be higher. They'll need less medical care. I don't know whether they will, over the total span of their life, it will cost less or not. But most certainly, the health benefits would be incredible.
What about the link to is there a possible link to higher rates of obesity because folks have substituted smoking with food, and especially the amount of cigarettes, because the pack per day.
When people, that we have a lot of therapies now that can about double the quit rate, nicotine replacement therapy. There's about 7 FDA-approved effective medications, whether nicotine based or some certain antidepressants. And one of the concerns initially among people was, to quit, that I might gain weight. Well, good advice if you're a physician is when somebody is willing to make that quit attempt, not only support them with what we have from the evidence shows them will help them the best, but also encourage them to be more active.
Thanks, Dr. Carney. My question is related to one of the pie charts you showed, which had the social determinants impact, or only 15% of health. And I was wondering if you think that that's truly that low, and because I think it would be higher, but
Yep.
and what you think the impact of that is on kind of the stigma around certain public health issues like addiction.
I think that original data was around from about 2000. It wouldn't surprise me if that proportion was a bit higher. All these are estimates. It just gives you a sense, and the big takeaway I take from that chart is the impact of habits and behaviors like tobacco use, poor diet, sedentary behavior, risk of chronic conditions is big. And that also, that healthcare, even if we can show everybody all at once today, our population health will not improve unless we also address these other things. So social factors may be bigger. I think that we see a lot of evidence that, for example, housing issues are huge. How can you take care of yourself if you don't have a place to live? It's very stressful. It's very hard. People having a job, people being literate, people being educated to a certain level. All those social factors contribute greatly to having an improved health of the population. And that's why we're finally seeing more and more connection and recognition of those factors as connected to healthcare settings. We're seeing population health, we call it, in the healthcare setting, where you're much more likely to refer people or be aware of social service agencies, public health agencies to help. I think that stigma and drug use, yes, of course. Stigma and mental health, we didn't talk about that at all. That's another controversial issue. But the stigma related to being poor or homeless. Yes, these are also factors that are not good in people's health, and we have to, again, as a society, try and address them.
Yes.
Hi. Thanks for a very interesting lecture. Just two quick questions. I just wonder, when you do a study and you rely on asking people. Now, I'm honest, but... And then another thing, and I hear this all the time, and, this is the result, and it's controlled for all other factors.
Right.
How is that possible?
Okay. First question is studies that ask people, are they accurate? Some of those studies are national surveys. We do them here. One's called the Behavioral Risk Factor Surveillance System, where they ask you about your habits and behaviors, access to health care. One's for youth that they ask in schools. It takes into account the fudge factor. And so there's questions in there, sort of duplicate questions that come back to kind of look whether answers are consistent or not, and then they throw it out. So even if the percentage was off by just a little bit, it gives you a ballpark. And it, certainly over time, because they ask these questions the same way over time, it sort of gives you whether you're getting better or worse. So yes, and that's why I showed you some of the studies that show when they put the accelerometer on to show whether people were actually moving as opposed to whether they said they were moving or sitting. So where possible, but the fact that you ask doesn't necessarily exclude those studies. The second question was about controlling for everything. All right, let's see if I can, when you're looking at one factor and like sitting, death. And then you have all these other factors that may be related to both of those. Like if you're overweight, well, it may mean you sit more. And it may be also an independent risk factor for getting a disease like diabetes that might have you die prematurely. So they put this in a computer model, and what they basically do is they take all those factors that are related to both, they're called confounding factors, they hold them constant, and so that they can look at this factor and this factor. It's called multivariate analysis, and it's in the scientific literature, and that's generally how they do that. And in my mind, what was the remarkable thing about these studies about sitting was that the common perception was that, okay, I'm good. I get up in the morning, I walk for an hour, I go to the gym, I do something, I'm active. And then I go to work and I sit all day. Or I watch TV for 4 hours in the evening, or something like that. That still, even if you were physically active, the sitting was an independent risk factor. I think that was to me surprising. That's why it got a lot of media attention. And I think as a consequence, both our medical and public health advice probably need to shift a little bit to include that and give people advice to get up and walk around, be active, move.
So as an engineer, I love public health, and I love all your graphs and all your analysis. I was wondering, from a public health standpoint, from the big picture standpoint, like for instance, as a statin taker, it seems like every man takes statins now that it's because and strokes and health and heart disease have dropped. We now know that painkillers were overprescribed, and there's an opiate crisis right now. I've read that ADHD kids, 90% of them end up smoking. These long-range, big-picture issues, like, for instance, Zika. We didn't have an epidemic. Was that a success for public health or just an accident? Who's looking at the big picture? Is there a national agency?
Well, in our country, generally it's the CDC, and that would be the big federal public health agency. A lot of the question was who's looking out for the big picture, and the federal CDC. Every state has a state department of health, county, local health department. Much of the data that I showed you for the country is also available in more detail, more granular by state. In some place by county, you can look at county health status to look at sort of what's shifting or not. Some of these things and the controversies, things just pop up and they come to attention, and you don't necessarily realize it because people were used to a concept of an epidemic as a disease epidemic, right? Cholera in England, for example. But then it was when people when I showed you those obesity maps, you know, what happened was those shifted over a long period of time before people went, whoa, this is really, really bad. And that then there was more research, more attention, more funding to do that. So I think that, you know, at the federal level, it's the federal public health agencies and the entire Department of Health and Human Service. At the state level, it's often your state health department. I also think that part of this, it gets into a question about, you know, how do we fund government budgets? And generally, when you look at last year's budget predicts this year's budget, which will predict, by and large, not 100%, next year's budget. It's really hard because there's so many needs. For example, if you go down to the state legislature here, there's so many needs to say we have to invest a little bit in things that take years to prevent. And so we see part of that is just somebody being looking and monitoring and publishing all this data to look for that, and then trying to translate that into evidence-based action that's adequately funded.
I was wondering how the HIPAA has affected your ability to collect data on trends in healthcare.
I don't.
I know this is off the
HIPAA
subject slightly, but
Yeah.
I'm concerned about how HIPAA has caused so much compartmentalization that you really
Right.
can't look at any individuals. You have to sort of be very broad
Right.
in your. Right.
I actually haven't heard that that's a major issue at a population level. A lot of the surveys I showed you were from expenditure data from, for example, Medicare, Medicaid data on a global and non-identified way. So I have not read about major impediments to research, for example. That doesn't mean they're not there.
Dr. Carney, this is more a policy question. So Vermont, of course, is a small state, and over the years, the state has taken specific steps to try to equalize things throughout the whole state. Like, for example, that every child in Vermont should get a quality education, and they put the law about the statewide property tax and so on. So you're familiar that there are health disparities throughout Vermont. So Chittenden County is the healthiest, highest income, best access to providers, and so on. So because healthcare is so complicated, which you try to convey, how would you approach this question of giving people statewide and other counties similar opportunities and similar information? Like right here, we have the advantage of coming to community medical school. Mm-hmm. That's a great advantage. That's only here. Mm-hmm. So really, from a policy perspective and the shortage of resources, money in Montpelier, where would a policy person begin? Now, this is just your thoughts.
I think the question is, how do we get that? There's a lot of information that's already available. And the question is, how do you make a concerted and systematic effort to get it out there? Department of Health, if you go on their website, you'll see many of these health indicators by county. You can see by county. You can go on, I didn't put this on your list, but you can look at, if you Google county health status, you can put in like any county in the United States and pull up a whole list of health status measures. That could be used by community organizations, hospitals, hospital service areas. We have school level information about youth risk behaviors that goes back to the school. So I would say there's a lot of information that we have, And we just need to let people, we need to make a concerted effort to let everyone know it's there, and to also make efforts so people can have conversations about that. That could happen through healthcare systems, the district offices of the health department. We have an AHEC program. We have a lot of community organizations. There's an awful lot of excellent Vermont health status data publicly available that can be shared with people.
So I heard a provocative quote recently that humans are about to send people to to Mars, and yet we haven't completely figured out what foods we will send with them. So it seems like there's another article every day I read that the ketogenic diet is better. Completely ruling out carbohydrates. So no, it's fine the next day.
Right.
First, is it true that we're still kind of debating this on the science level? And second, if it's settled, then why do we continue to hear articles that shoot down common wisdom?
Here's the good news and bad news about our availability of information in the media. There's stuff there on every aspect of health every day. And then the question is, which of it do you believe? And which of it do you actually make changes in your own health? I think you have to be very discriminating. And because at a policy level, all these like dietary recommendations go through scientific advisory panels. They go through federal agencies. There may be some political efforts there in that step, but people use reputable science to make the best available health advice for the public. All right. So then, how do you decide from these media reports? I just say, be careful. If something sounds too easy or too good to be true, it might be. One of the things that I put on your list of general references is called Health News Review. They do a very good job of looking at some of those articles and saying, oh, but the methods on this were. And I think it's something that bridges the gap in part between some of the new scientific studies and the media, what the media says about them. So I would say the other thing that there are things from the National Library of Medicine, Guide to Healthy Web Surfing, to show you about high quality sources on health. Be very discriminating about that, and to look at some of these sites and ask questions. Okay. All right. Thank you very much.